Hi, Professor Graff. It's Darcy, and I'm here to go over asthma and the way our lungs function with you today. So, first, we have our nifty little project that we created that I was able to do all by myself here. This represents the anatomy of the lungs, and I'll show you how that works here. So, let's just go through it piece by piece. So, here, the straws, these actually represent your bronchi. Those are like the little oxygenation highway. You take a breath, it comes down this little highway, and then it fills in your lungs. You have your right and left lung here. They expand, take in the oxygenation, push the oxygenation into the blood, and then so forth to the rest of your system. And then you have your diaphragm here, and this is kind of like a little machine that helps these lungs function. And here's what I mean by that. When you take a breath in or you inhale, you have oxygen that flows through your bronchi. As you inhale, your diaphragm's actually going to contract, and then that's going to help your rib muscles expand, giving the lungs room to fill with air. And so they'll fill, see, as I contract that, they'll fill up with air. And then as you exhale, the opposite happens. The diaphragm actually relaxes, then the lungs contract, and it pushes the waste product back out the bronchi. So you take a deep breath in, diaphragm contracts, lungs expand, breathe out, diaphragm relaxes, lungs constrict, and waste products out. So that's how it should function. But when we're considering a disease such as asthma, which is a respiratory disorder, it's caused by chronic inflammation in your airway passages here, making it hard to breathe, causing shortness of breath, reducing the oxygen flow properly. So like I said, asthma is actually a chronic inflammation disorder. What happens is you'll have a trigger, either allergens, pollen, exercise, stress, medications, something that triggers an inflammatory response. What it actually does is it triggers cells, mast cells, and mediators, which are chemicals that actually start that inflammation process. As those are released, your body responds by causing inflammation. It's causing vasoconstriction, bronchoconstriction. So these are the bronchi, so these constrict. And as you can tell by the model, if these constrict, then air can't properly make it to the lungs appropriately, and carbon can't be appropriately released. So it progresses, it becomes a persistent issue, the inflammation progresses, and we have an issue with airflow limitation. What it can look like with asthma, the common symptoms are things like cough, shortness of breath, wheezing, adventitious lung sounds, hyperventilation, the patient's trying to get in enough oxygen because everything's constricted and inflamed and it's not flowing, can cause other responses in the body. If oxygen's not making it to your lungs, then your lungs aren't passing oxygenated blood to the rest of your organs and body, and they need that. They need the oxygenated blood to function appropriately. So you might have tachycardia, you might see changes in neurological status as the oxygenation decreases in a very serious acute asthmatic situation. A lot of people who suffer from asthma do suffer from it on a chronic basis. It's something that they continually have to either treat to prevent, or they have something like a rescue inhaler on the other end. So there are certain medications, and I kind of gathered a few that you might see in a patient who suffers from asthma. Let me go back 1 second and just, as the condition progresses, it can cause cyanosis and severe hypoxia. So it can get, like I said, very quickly, very fast. An acute situation can become life-threatening very quickly too. So I just want to make sure I mention that. Again, so going back to the medications that you may see in a patient who's asthmatic or suffers from asthma. The first one is a short-acting adrenergic agonists, excuse me. These are for acute relief or for prevention of exercise-induced asthma. So something like where you take a puff before you actually start the activity. One medication that relates to that is terbutaline. The next medication is an anticholinergic, and they reduce the, I'm just going to read it word for word here, reduce the intrinsic vagal tone of the airway. So it keeps the airway flowing. That's like opens your airway up. It's your Spiriva. That's an example of one of those. You have your corticosteroids, and then steroids, again, they are there to help reduce inflammation. So you think of it that way. They are effective in improving airway function and relieving some of those symptoms. So that's like your Flovent. The last couple were new to me. One is a leukotriene modifier, and these are anti-leukotrienes are potent bronchoconstrictors. So the modifiers help alter the permeability there. Things like Singular, that is one of those. And then you have your immunomodulators, and they work on the mast cells to regulate your immune system response. And one of those medications would be like methotrexate. So adrenergic agonists, anticholinergics, corticosteroids, leukotriene modifiers, and immunomodulators. Such a mouthful. As nurses, some of the other considerations that we might want or intervention, so to speak, or nursing care would be always assessing the patient's respiratory status, especially with severe symptoms. You want to look for accessory muscle use, nasal flaring, hyperventilation, signs of poor circulation, signs of reduced oxygenation. You want to be listening to those lung sounds. Is there wheezing? Is there crackling? Anything adventitious there? You want to be monitoring the rest of their vitals. As you start to lose the ability to oxygenate, your body compensates, your heart compensates. You might experience tachycardia. You might see that in a patient with asthma or suffering from, chronic asthma. Keep an eye on that pulse oximeter. In planning care and interventions with the patient, you'd want to make sure that you can get an airway, you have what you need, that we are helping them get rid of any secretions that might have built. You want to educate them. Big part of asthma is patient education on how to use preventative medicines, how to use the reactive medications, how to identify triggers, and what to do in the case of an asthma attack that couldn't be prevented. Assessing patient history, keep an eye on the respiratory status, going over the medications, providing them these medications that would probably be ordered by a physician. Fluids, prevent fluid volume deficit or dehydration. And then one other thing that I thought was kind of cool is I did see an acute care action plan, and it's like an asthma action plan to try to help the patient feel more in control of a situation when an asthmatic crisis comes, and it's like a plan of action that the patient can follow. So to evaluate some of those interventions, you want to be looking for proper O2 saturation, the reduction in hyperventilation, normal regular respirations with no accessory muscles, capillary refills, color, tone, those things to evaluate your interventions as you're working with an asthmatic patient. So that was a lot of information, super fast, but it was very interesting. I liked the project. I love learning about asthma. My son actually had asthma more in his youth. He's not had a problem with it in a long time, but it was an issue. We had one hospital stint with the asthma when he was younger, so we'll talk to you soon.